Good morning, everyone. Welcome to today's clinical meeting. We'll start off with the first presentation from Medicine 3, Dr. Brightlin, It's Udder Chaos.
Good morning, everyone. I'll be presenting on behalf of Medicine 3. So the patient details are shared with the patient consent. Coming to the case scenario, Mrs. Ruba, 26-year-old lady from Ronipet. She is a primigravida and 10 weeks plus 1 day of gestation, presented with complaints of fever for 10 days. History of presenting illness, patient was apparently normal before 10 days and then she developed fever, which was high grade associated with chills and rigor, which is relieved after taking tablets. And she also had generalized fatigue, myalgia, and headache for 1 week. She didn't have any features of abdominal pain, vomiting, no history of burning, iteration, or hematuria, no cough with expectoration or breathlessness. She didn't have any rashes, no joint pain, no neck stiffness or photophobia. So coming to the past history, she did not have any comorbidities. So the patient boils the milk and drink, but used to help clean and take care of the cow. That is the only history we were able to take. Obstetric history, her LMP was 13/4/23. Estimated date of delivery was Jan 18. So coming to the examination, patient was vitally stable. On presentation, she had temperature of 98. She did not have any pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema. Systemic examination wise, she didn't have any localizing findings. So the patient presented with the syndrome complex of acute undifferentiated febrile illness. So the differentials considered were okay. So we also thought the same things. The differential considered were dengue fever, scrub typhus, malaria, typhoid fever, and brucella. So coming to the investigations, hemoglobin was 12.3 with a total count of 3,800. Platelet was 1,44,000. Urea create were normal and LFT showed mild transaminitis and the urine analysis were normal. So the picture showed we thought of dengue. So we went ahead with the serology. Dengue came as negative, scrub was negative, malaria was negative. So in pregnancy, asymptomatic bacteriuria has also to be treated. So we sent urine culture which grown CRO E. coli. So we started on polymyxin after discussion with the ID department. So urine culture shown CRO E. coli started on polymyxin. So on day 5 on polymyxin, patient had persistent fever spike. USG we did showed no renal abscess, but blood culture had grown brucella. So my topic will be approach to the brucellosis in pregnancy. So coming to the brucella, it's a zoonotic disease usually spread from the cattle. So other names for this brucellosis is Andalusian fever, Malta fever, and Mediterranean fever because it's common in that region. So coming to the organism, it spread the infection to human beings. The arrow marked in red are the high risk for this zoonotic infection. So the goat, pig, and cattle, and sometimes dog has the propensity to be to transmit the infection to human beings. So other species, they don't have the risk of zoonosis. So coming to the prevalence of brucellosis in pregnancy. So incidence of brucellosis in pregnancy in endemic region is 0.4 to 3.3 per thousand. And the seroprevalence is 1.5 to 12.2% in the endemic region. So this is the seasonal, the brucellosis can have 4 different forms: acute, subacute, chronic, and relapsing forms. So in the different form, the brucella has a seasonal distribution all throughout the year. It is more common in the time of May and June, and after that it has a drop, and again it has a peak in the September and October time. So coming to the agent brucella, so they have usually 3 main forms that infect the human beings: Brucella melitensis, canis, and abortus. So the organism is usually killed by boiling and pasteurization, but they can survive up to 2 months in cheese made from goat or sheep's milk, and they can survive at least 6 weeks in dry soil contaminated with the infected urine, vaginal discharge, or placental or fetal tissues. They can survive 6 months in damp soil or liquid manure kept in cool, dark conditions. So coming to the risk factors for the infection in human beings, if the patients had consumption of unpasteurized milk or unpasteurized cheese, or they have a contact with animals, or consumption of colostrum, family history of brucellosis is not common, it's very rare, or the dealing with unvaccinated animals, this is common in this Mediterranean region. So the most common is consumption of the unpasteurized milk and consumption of unpasteurized cheese. So the mode of transmission will be 3: ingestion of unpasteurized milk, contaminated milk, raw cheese. Inhalation is more common in people working in laboratory handling brucella and in slaughterhouses. Mucosal exposure is also common in slaughterhouse and meat packing employees. So coming to the stages of brucellosis, acute will be less than 8 weeks, subacute 8 weeks to 1 year, chronic more than 1 year. So our patient had acute presentation less than 8 weeks. The patient had fever only for 10 days. So the common presentation of brucella is fever with musculoskeletal pain. There is a fever pattern in brucellosis. It has an undulating pattern. That's why it's called undulant fever. So the patient will have persistent fever for weeks. After that, they will be having an afebrile fever that may be followed by a relapse. Again, the patient will have fever and then followed by a afebrile period, and is usually associated with musculoskeletal symptoms in about 1/2 of the patients. So the other clinical features that can brucellosis present is neurologically, the patient can have meningitis, abscess, and encephalitis. Genitourinary is also second most common after the musculoskeletal. The male can have epididymoarthritis, tubo-ovarian abscess. Cystitis and interstitial nephritis are not common, but it can present in that way. Musculoskeletal, this pain and arthralgia is the most common presentation after fever, and they can also have osteomyelitis and septic arthritis. Hematological cardiovascular pulmonary, it usually happens in severe disease. So they can present as hematuria, thrombocytopenia, and culture negative endocarditis, and sometimes pneumonia. So the arthralgia and this arthritis picture, you usually confused with the TB. So the clinically they cannot be differentiated. So radiologically, these both can be differentiated with the following tabular column. So in brucellosis, lumbar and other spine is common. Tuberculosis, dorsal-lumbar spine is the common. In brucellosis, multiple vertebrae is involved. In tuberculosis, contiguous vertebrae is involved. In brucellosis, discitis is late, and in tuberculosis, it's early. The body of the vertebra is intact until late, but in tuberculosis, it's lost early. So canal compression is not common in brucellosis, whereas it's common in tuberculosis. Epiphysitis, it's present in the anterosuperior part of the vertebra, whereas in tuberculosis, upper and lower disc region can present in central as well as subperiosteal region also. So osteophyte, this is a anterolateral parrot beak appearance will be there. In tuberculosis, it is not common. So deformity will be wedging, and wedging is uncommon here. In tuberculosis, a gibbous and anterior wedge is common. A recovery is whole body is recovered and there will be sclerosis. In tuberculosis, it is variable. Paravertebral abscess is very small and localized, whereas in tuberculosis, it's common and there is loss of transverse process. Psoas abscess is rare in brucellosis, whereas in tuberculosis, it's more likely. So this is the parrot beak appearance showing the anterosuperior corner of the vertebra destruction in the brucellosis. So the symptoms in pregnancy, usually the patient presents with fever with musculoskeletal pain or other system involvement, whereas in pregnancy the patient will have non-specific symptoms and they present as mild forms of brucella. So they may have fatigue, excessive night sweats, headache, weight loss, and myalgia, arthralgia. But pregnant patients sometimes complains of low backache, which is not alarming to be considered a brucella. So the pregnant women have non-specific symptoms. So the delay in diagnosis of brucella in pregnancy is common. So unfavorable outcomes of brucella in pregnancy, the obstetric outcomes, the patient will have spontaneous abortion in the first trimester and preterm delivery or intrauterine fetal death in this third trimester. As for the infants, they will have low birth weight and developmental delay in congenital malformations. So this early treatment can be done to prevent unfavorable outcomes in pregnant women. There is in literature stored that measured the outcome of pregnant women with brucellosis. So out of them, they 53% had spontaneous abortion in the first trimester. And after that, they were started on treatment for the brucellosis and given treatment for 6 weeks. After the planned pregnancy, 31% had abortion and rest had normal delivery. And 55% infected in the first trimester had spontaneous abortion. So our patient has first trimester brucellosis, so is more at risk of spontaneous abortion. However, this shows that the patient who are treated early for brucellosis can have this prevention of spontaneous abortion. If at all had a spontaneous abortion after treatment, they may have normal delivery. Only 31% had a abortion after treatment. So the diagnosis is usually by Roux Bengal test or serum agglutination or by blood culture test. So our patient had blood culture growth brucella. So treatment guidelines is for the patients who doesn't have musculoskeletal or other system involvement. Usually we treat for non-pregnant women, it's doxycycline plus streptomycin or doxy plus genta or doxy plus rifampicin. For pregnant women, it's cotrimoxazole with rifampicin. For the musculoskeletal involvement, in addition to the streptomycin group, they added rifampicin for the non-pregnant women. For the pregnant women, ceftriaxone has to be added. And for the neurobrucellosis, in non-pregnant adults, ceftriaxone is added, and in pregnant women, ceftriaxone again is both are same for the neurobrucellosis. So the treatment is usually for 6 weeks. So our patient has no musculoskeletal manifestations or involvement of other systems. She presented only with fever. So she was started on cotrimoxazole and rifampicin, planned for 6 weeks of treatment. So coming to the summary, the risk factor for this brucella infection is unpasteurized milk consumption and unhygienic practices. So they have presentation as unbill fever, and they are at increased risk of abortion and preterm pregnancy. Early treatment reduces adverse obstetric outcomes. Thank you.
Thank you, Brightlin, for that presentation. Any comments or questions from the audience?
Any risk factors that you will find out?
So she used to tend to, she has a cow shed near the home. She drinks only pasteurized milk, but she tends to the cow's delivery, everything she does in her home, sir. So that risk factor we found out in it.
She takes care of the cow.
Yes, sir.
So basically in a close contact.
Yes, sir.
With that. So that's one.
Yes, sir.
What are the antibiotics you give in the pregnancy, sir?
Cotrimoxazole and rifampicin, sir.
She responded.
Yes, sir. After that fever has settled, we discharged her 2 days ago. She'll be coming up after a week, sir, for follow.
Have we planned screening for household contacts? That's also important because I think there are cows at her home and a lot of people seem to be handling the cows. So it's important to screen for household contacts also. Any other questions or comments? Okay, we'll move on to the second presentation from Medicine